Hello, good morning, everyone. We have completed our first lecture. So I'm moving on to the second one. So our second speaker, we are very delighted to have Associate Prof. Tan Kit Moon. She's a geriatrician currently working in the Department of Medicine in PPUM of University Malaya. She's received her medical degree from Trinity College, University of Dublin, Ireland in 1999, and she completed her specialist training and received a certificate of satisfactory completion of specialist training in geriatric medicine from the Irish Committee of Higher Medical Training, Royal College of Physicians, Ireland in 2009. So she has actually I've listened to her lecture in Malaysia Stroke Conference, and I find a very insightful lecture. So she has interest in stroke, atrial fibrillation, dementia, osteoporosis, hypertension in the older patient, and comprehensive geriatric assessment of the complex older person. So without further ado, I would like to welcome Prof. Tan Kit Moon to deliver her talk today. And the floor is all yours, Prof. Thank you.
Hi, good morning, everyone. Thank you, Dr. Nazrina, for a lovely introduction. And it was a great talk by Dr. Koo earlier on. Nice to see about 100 of us online. And I'm just hearing my own introduction. It's like I was graduated from medical school in the last century, and our medical students now, they're born in that year. So it's a bit amusing whenever I meet the medical students. So let me try and get this slideshow going. Let's see. New slide. Apologies. Trying to get that out of the way. Height floating control. Yeah, so everyone, you are emergency physicians, most of you, and you'll be seeing so many more older persons in your emergency department. So it's very important to recognize delirium because of the various implications and poorer outcomes of people with delirium. So my topic, my name is Tan Kit Man. I'm a geriatrician, and my topic is delirium in older persons, recognition, which is the first step of helping the older person, and then management. So what is delirium? We'll keep it in simple terms first. It's an acute confusional state with alteration of consciousness level and reduced ability to focus, sustain, or shift attention. That's a very important criteria. Later, I'll go into the diagnostic criteria. We have to remember, delirium is a medical emergency, like brain failure. We have heart failure as well, for example, they decompensate. So brain failure, delirium is a medical emergency. We don't take it lightly when the family members tell us that my father is not the same. When I last visited him a week ago, he was very clear doing everything. And this week, he's just not sharp. He's very slow. And I think something's wrong. It is usually poorly recognized or underdiagnosed, and it leads to poorer outcomes like longer length of stays, readmissions to hospital, ending up in nursing home, and also deaths. Hence, very important to spot it. Who is likely to develop delirium? A frail older person, people with multiple comorbidities, pre-existing dementia, and any new acute situation or illness. We also know that a person without dementia can also develop delirium. I'd just like to show what we call the clinical frailty scale here on the right. And it's developed in Canada. It's a nice scale where if we take a very good history on the person's ability to do personal activities of daily living and instrumental activities of daily living, we may be able to classify them into very fit all the way to living with very severe frailty. They also have frailty, scoring frailty in people with dementia. So obviously people with dementia and at the higher levels of frailty, they are more likely to develop delirium with any new situation. I always joke with our medical students as well. I show them this picture that we must never just match the person to the picture. So if someone comes to the clinic being pushed in a wheelchair, That doesn't mean they're automatically 7. We actually have to take a very good history about their personal activities of daily living, which is ability to care for themselves, bathing, toileting, dressing, feeding themselves, can they walk, and the instrumental activities of daily living, which is go out for shopping, driving or transportation, managing their finances, and etc. Means instrumental activities of daily living is how they interact with society. Personal activities of daily living is how they care for themselves. So by doing that, we will know how fit or frail a person is. We also must know that being very frail is not the only criteria to decide their treatment plan, whether for resus or not. So we mustn't ever write in the notes, clinical frailty scale 7, not for CPR intubation. It's a little bit more than that. We have to take other things into account. So frail older persons frequently have the geriatric syndromes, instability or falls. You see many people who fall and fracture or have subdurals in your emergency department. Immobility, they may be able to walk only with a walking frame or someone holding them or mostly wheelchair bound. Impairment of cognition, dementia or delirium, incontinence of bowel and bladder, iatrogenic events. Really frail older persons more likely to suffer iatrogenic or healthcare associated events, impairment of hearing, vision, and swallow. Why we list this out whenever we speak about older patients is that if we do not screen for these conditions, we don't actively ask, the family members and the patient may forget to tell you, because in their eyes, this may be a natural part of aging, but actually it is not. So our common example will be Tun Dr. Mahathir, who is still looking very dapper and going around in his suit and giving opinions. We also have Queen Elizabeth. She's in her 90s, but unfortunately lately, I believe she had COVID and her mobility level was greatly reduced after that. So we screen for these geriatric syndromes when we see a complex older person. Allow me to advertise a bit about geriatric medicine and the aging population. This is the league table of people aged 65 and above in the world. Where's Malaysia? It's quickly highlighted here. We are still a relatively younger country compared to Japan, which is at 1 in 4 people. 1 in 3.6, of course, is not a sensible statistic. So 28% are over 65 years old, 1 in 3.6. That means we have very much fewer younger people to look after the older ones, both financially and physically. In Malaysia, we are at 7% or 1 in 14, and Singapore is at 1 in 9. Oh, okay. Oh, sorry, I wondered if there was the narration for the previous slide, which I forgot to take out. So hence I paused for a while. So as we can see, from the year 2000 to 2020, our total population increased by 40%, from 23 million to 32 million. But we can see that the older persons increase much faster. From 1 million, they became 2.3 million in 2 decades. So the increase is 155%. So older people, the population actually increased by 4 times as fast of the general population. Hence, we really must look after, know how to look after the older person very well. And this is the population demographics, the pyramid. And we can see that in 2020, it was in the year 2000, it was pyramid shaped. But in the year 2010, it was more pear-shaped. So that just indicates that the population is aging. Okay, let's go back to our main topic. How prevalent is delirium? I'd like to show you data from prospective studies and retrospective studies. There's a prospective study by Dr. Inouye. If you see the term Inouye, Dr. Sharon Inouye, she's a world expert on dementia and delirium mostly actually. So her articles are very well received and they read very well with good information. They found that between 1/3 to 2/3 of older hospitalized patients had a certain degree of delirium. This is a prospective study, and we know that prospective studies, people actively go looking for the cases with certain diagnostic criteria. However, retrospective studies means they just open medical notes to see whether there was presence of delirium. They only found it to be 2 to 5%. So this really indicates the possibility of under-detection and under-recognition. And what is dementia as opposed to delirium? Dr. Koo has very nicely put it across already, and it must be severe enough to affect A, B, C, activities of daily living, behavior, and their cognition. So A, B, C must be affected to say it's dementia. If it's minor forgetfulness, I went upstairs, I forgot what I wanted to get from the bedroom, but I remember later, that is not dementia. That is some subjective memory problems. But of course, the person can benefit from further evaluation if they're worried about it. Types of dementia, it's been gone through in the previous talk. And the difference between dementia and delirium, very important. Dementia, the time frame is much longer. Months to years. Of course, there were the red flags for the rapidly progressive dementias or cognitive problems over months. Then delirium, it appears usually from hours to days, and it is potentially reversible, caused by an acute event. And again, persons with dementia are more likely to develop delirium. This is a nice article, and it's freely available online, free of charge. Management of delirium and agitation in the older emergency department patient, the ADAPT tool. And the author is Shenvi, so you can get this later. They have a nice table in it that there's distinguishing features between delirium, dementia, and psychosis. There also should be one for depression, because some people are really quite catatonic and slow if they're heavily depressed, untreated, even with a very poor social circumstances. So delirium and dementia, acute versus gradual, fluctuating, dementia is progressive. So I won't go through this whole table, but just to illustrate that, you know, we can easily misdiagnose somebody if we don't take a thorough enough history. The caveat is that in dementia, there's something called BPSD. And frequently, this is what breaks the camel's back in terms of the carer's stress and looking after an older person. It's called behavioral and psychological symptoms of dementia, which includes all the spectrum of changes in the behavior. The challenging behavior could be they're quite argumentative, accusatory, hallucinations, sleep-wake pattern disturbance like wandering at night, and meaningless repetitive activities that they do. The problem is delirium can have all these features too. So really the key is the history from the family members. Now let's go back to delirium. I digressed a little bit about dementia and how to differentiate between dementia and delirium. And also we have to consider depression and psychosis. What conditions can precipitate delirium? Really, any change in a person or the environment can precipitate delirium. The simple things on the ward, we look for the physical causes on the patient. Do they have a pain somewhere, especially post-operative or undiagnosed fracture? I have an excellent specialist who was with us on the ward these few months. Thorough examination picked up a hip fracture that no one else picked up, and also a subluxation of a right shoulder. So a very conscientious, thorough doctor with a mindset to look after a frail older person, they can pick up a lot of things. Pain, constipation, urinary retention. Are they hungry? Are they hypoglycemic? Or have they a severe itch that they can't scratch, or something that's really making them uncomfortable? Pressure ulcers and pressure points also can be quite uncomfortable. Environmental, is it too hot or too cold? Now, our hospital is very nicely air conditioned, but sometimes if the weather is cold outside or the thermostat's not working, we could actually be 20, 21 degrees. And for an older person who's not used to aircon at all, even in their own home, this can be really, really distressing and make them quite agitated. Other environmental or social circumstances, like they just moved homes from one child's home to another child's home, or they moved into a nursing home. In the ward, they moved wards, transfer care from one ward to another. By the fact that they're admitted to hospital from their own home, change in environment, or even things like their own home, the next door is having renovations and banging. So it can tip them off to a state of confusion. So you really have to take a very detailed history. Another patient of mine, we took a detailed history. It turns up that there was a birth of a new grandchild. And with all the crying and everything, it disrupted the household. And psychosocial, like death of a family member, they experienced a robbery, they were in a car accident, or they suffered some financial loss, or was a victim of a scam, or assault, or perhaps even a new caretaker was hired to look after them. So that can trigger off a period of disorientation and delirium, especially in one person who already has dementia. The medical conditions, any new illness can cause delirium. The common ones, stroke, seizure, heart attack, fall and fracture, etc. General anesthesia. Then infections. Can we please think beyond UTI and pneumonia? They are the most common diagnoses. And sometimes we are not so certain, but whether they truly have pneumonia or UTI, but they seem to be the most common diagnoses. We have to search hard whether there's any intra-abdominal problems. There's cholecystitis, appendicitis, diverticulitis, for example. Ileopsoas abscess, we find that a good deal of patients, if they do have this, it's a delayed diagnosis. We have to remember to flex the hips. Spinal abscess, septic arthritis. It's a bit more obvious, I suppose, septic arthritis. You can see the swelling, it's red and hot. There's cellulitis as well, abscess formation, Fournier's gangrene and perineal area. We've also had cases where diagnosis is pneumonia, and then there was no time in the emergency department to strip the patient and do a very thorough exam, but we also found some abscesses in the vulval area, the perineal area. That one I remember clearly. We actually had to transfer to gynecology ward, and we say we help consult on your ward. Infected pressure ulcer, dental abscess. Don't forget to check the oral cavity. And salivary gland abscess, for example. Then there's the encephalitis and meningitis. So please, a very, very thorough examination. We frequently need help. One person cannot examine a frail older person all by themselves. We need to coax them, pujuk, get the family member to help and reassure, or a nice patient nurse. Whenever we deal with a patient with delirium, we always explain what we're going to do. We don't just turn them, sit them forward, move their bed up and down. They get even more shocked and more delirious. So what conditions, what other conditions? Medications, a new medication, those with anticholinergic properties, sedatives, opioids, digoxin, psychotropics, ciprofloxacin, steroids. Steroids we used a fair bit in the COVID wards, dexamethasone, etc., if they were having very severe lung changes. And also in a routine setting, my hospital, the radiology department requires steroids prophylaxis if the person had a drug allergy as well, or if they had asthma or bronchospasm as a diagnosis. So we did have a few cases of the person look all right. You give them steroids as prophylaxis for contrast induced, or for allergic reaction, then they got very confused. A drug overdose of any sort, drug-drug interactions. Some drugs can potentiate actions of others. So Medscape has a very nice free drug interaction site that you can type in a whole list of medications and they'll tell you what are significant dangerous interactions. Then always ask if there was a recent change to medications if a person presents with delirium. For those with dementia also, I might say that we have to ask who administers the medications to them. We had cases of accidental overdose because the family felt that, oh, my mother will do okay with the Monday to Sunday drug pill box. You've seen that before, Monday to Sunday. But the poor lady, yes, today's Monday, I took my pills. 3 hours later, oh, today's Tuesday, I'm going to take Tuesday pills, but it's still Monday. And surprisingly, I had one patient who did that 6 times in 24 hours. So she was severely overdosed. Pill boxes unsupervised is not a great way of medication adherence for someone with dementia, even though it's early dementia. So those are little stories I like to tell, so please bear with me. But sometimes the little stories help you remember things. This is also another table from that same paper. Do download it. It says common important precipitants of delirium, agitation, or confusion. The readily reversible causes you can treat in ED, like hypoxia, hypercarbia, hypoglycemia, hyperglycemia, etc. Infection we mentioned, neurologic we mentioned, medication-induced adverse effects, we also mentioned them, antihistamines, and also the atypical sleeping pills like Solpidem can also cause nightmares and agitation in some older people. Toxicology. Then don't forget about alcohol or benzodiazepine withdrawal. Some people who are alcohol dependent or benzodiazepine dependent, suddenly they run out of stock. They can get very delirious. I'm sure you see that in emergency. So metabolic causes, cardiopulmonary, environmental, lack of hearing or vision aids. I forgot to mention that. So if they have hearing or visual impairment. So how do we diagnose delirium? Before we go into the fancy diagnostic criteria, we will say this. The cornerstone of diagnosis means the most important point of diagnosis is to determine the the person's baseline cognitive function and behavior, and the time frame over it develops. It's supposed to be from a reliable carer who knows the patient well. And then a very thorough physical examination. Ask for help from a family or staff member when examining. When we have a bit more time on the geriatric ward, we have the multidisciplinary team to help us. It's everybody, including nurses, pharmacists, therapists, doctors. That formally we call that a comprehensive geriatric assessment. I know you cannot do that in the emergency department, but you'll probably be able to take a few quick basic history. But nonetheless, the CGA is the medical and medication history, nutritional assessment, social history. Then we focus more on these, the functional status, psychological status, looking for dementia, delirium, depression, anxieties, environmental assessment. So I'm also now advertising geriatric medicine. So the cardiologists do angiograms and the gastro people do scopes. We do this very fancy thing called CGA with the help of others. It's actually just as tiring. Some of our family meetings are actually very long when we have to explain or prognosis and what's going on. So let's go to criteria to diagnose delirium. Remember AFIDA. That's a nice name. So it's AFIDA. It's not actually a diagnostic criteria, but it's just my mnemonic for everyone to remember how to look for delirium. So A, acute in onset, F, fluctuating course, I, inattention, D, disorganized thinking, A, altered level of consciousness. So remember AFIDA. Some of you will know somebody called AFIDA. I think most of us do. Now let's go through one by one. I think the acute in onset is self-explanatory. I didn't have a slide on that. So fluctuating course, it can fluctuate during the course of the day. They can be better at certain times and worse at others. It affects their thinking, cognition, judgment, and behavior. So you might say this morning look okay on ward round. Afternoon, oh, you're a bit more confused and didn't recognize me, whereas I saw in the morning. However, in dementia, the behavior and thinking can also fluctuate, in particular for Lewy body dementia that was mentioned by Dr. Koo already. Dementia in general also can be worse in the evening or nighttime when the person gets more fatigued. The old-fashioned term is called sundowning, but we rarely use that now, but we do know that this phenomenon exists. The delirium could be hyperactive, and there'll be the noisy person on the ward, always looking for attention. Hypoactive, which is the most frequent, up to 80–90%. And somehow the outcome of the hypoactive delirium person may be worse because they don't ask for attention. Then people will say, oh, this uncle, very quiet, easy to jaga. It's usually a mixture of both usually. There's also delirium without motor symptoms. They are quietly delirious. They look very polite. They're chatting to the doctor, but in their mind, they're thinking lots of things and being very frightened. But to keep things simple, we'll say hyperactive, hypoactive, and mixture of both. Inattention means difficulty sustaining attention. You start speaking to someone, they may become restless during the interaction or picking at things, or they look away, and they're unable to focus on the topic of conversation or task at hand. Probably cannot do 2 or 3 stage commands maybe. Disorganized thinking is the D. Irrelevant content of conversation, jumps from topic to topic, maybe overly friendly and thinks you're the nephew or you're the neighbor's son next door, that sort of thing. They're unable to perform a task well that they're usually able to perform. They may have unusual thoughts or perceptions, hallucinations, mistaking someone for others, thinking they are somewhere else, like at the hairdresser's or on a cruise ship. They're mixing up reality and thoughts. And A is altered level of consciousness. They're very drowsy or sleepy or tired. And these are the hypoactive deliriums who are at risk of becoming dehydrated, malnourished, and developing bed sores or pressure ulcers. Then there's the hypervigilant, unable to sleep, and restless. So screening tools for delirium, that's what you read about in research articles as well. And we can use them in clinical practice. I do think AFIDA is much easier to remember, but it's not validated anyway. Screening tools for delirium, that's where I got AFIDA from. It's confusion assessment method. You have to have both features A and B and either C or D. A would be acute in onset and fluctuating course. B is inattention. Then either C or D, which is disorganized thinking and altered level of consciousness, hence AFIDA. This is officially the CAM assessment, confusion assessment method. And again, it's by Dr. Sharon Inouye. This is the 480, where there are different segments and it takes about 5 to 10 minutes to administer. And the score of 4 or above, possible delirium plus minus cognitive impairment. So, and 1 to 3 is possible cognitive impairment. But the very important part is acute change or fluctuating course. There is My 480, which is the Malaysian version of 480. It's not yet published. One of my colleagues had a master's student who modified it with the attention of with the approval of the original people who made 480. It's My 480. For attention, instead of saying the months of the years backwards, it says here achieve 7 months or more correctly, that they ask the person to count from 20 to 0 backwards. It's felt that in Malaysia, if you ask people to name the months, they'll just say it's the 12th month, 11th month, 10th month. So counting backwards may just be as simple. Whereas I suppose in English language, you have to go December, November, October, September. See, we're struggling if we're tired. So let's go through this Shenvi paper again, the ADEPT tool for ED. Assess, diagnose, evaluate, prevent, and treat. It's for confusion and agitation in the elderly ED patient. Whatever it is, we should screen all older persons who attend emergency or be admitted to the ward for delirium. So we assess them to perform, we have to perform a thorough evaluation to determine the underlying cause. So just assess very well the person, then diagnose the delirium by screening for it. We actively look. We may forget if we don't actively look. So please, after today, when you're next on duty, every older person, apply it, a screen for delirium, and then have that as part of the referral to the medical team, for example. This person has pneumonia and delirium. Evaluate, perform the thorough evaluation, the tests that are necessary, then prevent further worsening of the delirium, or if they are not delirious, try to prevent delirium. mostly by non-pharmacological means. Then we treat. If there's delirium present, we treat. Multimodal approach, verbal de-escalation principles, and oral medications considered. Avoid benzodiazepines unless possibly it's due to withdrawal. And we have to be careful to prevent harm and minimize side effects from their hospital treatment. So prevent iatrogenic events. So the medical review, you may need help. Medication review, very important. The investigations, general and targeted. Mostly, we end up taking a lot of tests. I agree, yeah, most people get a lot of tests done. CT brain is warranted if there was trauma or a fall, on anticoagulation and focal neurology. But I can understand people's point of view that they have lower threshold to do a CT brain, because in a delirious older person, they do not cooperate with a full neurological examination. And delirium itself is a sign of a brain failure, basically. And then where warranted, lumbar puncture and EEG. EEG, for example, if you feel that it may be a post-ictal confusion or some sort of encephalopathy going on. Prevention of delirium. This is the multi-component non-pharmacological they're talking about. Early mobilization. Mobilize doesn't mean start walking immediately. It's at least sitting them up in bed and sitting them out in a chair, so that they're not always lying down and looking at the ceiling, and so that they can look around. Adequate hydration and nutrition. Orientation. A big clock and calendar on the wall. Of course, the clock must have battery. I found a few clocks on the ward walls that have no battery, and somebody forgot to change the date if it's not automated, so that's no use. Sleep enhancement at night, a quiet environment. You'll be surprised, or we are not surprised, how noisy the ward is at night, and many people cannot sleep. Then night after night of sleep deprivation, their mood and they gets bad, and they also get delirious. If they are very stable patients, we may reduce observations taken at night and minimize your nighttime medications, or take away, don't give the 4 a.m. feed if it's NG feeding. There's no need for that, because we usually don't eat when we're sleeping anyway. If they have the usual hearing aid and spectacles, that'd be good. Avoid multiple moves within a ward, and if possible, same staff to look after. We remove urinary catheters, IV lines, NG tubes, oxygen tubing as early as possible. We do not recommend urinary catheterization for convenience in the emergency department. It has caused a lot of grief to the patient, hematuria, traumatic hematuria, injury to the urinary tract if they were delirious and pulled it out. And also iatrogenic catheter-associated urinary tract infection. Then when they reach the ward, if it's not a geriatric ward, they're very slow to decatheterize. When we do the famous TWOC is written in the chart, trial without catheter, it fails because their bladder had deconditioned in the last 6 or 7 days. It's chronically drained because there's a tubing in. So do not put in a urinary catheter because they cannot walk to the toilet. It will cause severe harm to them. Of course, we put it in when they're in acute urinary retention. We need it in septic shock, and when they have acute pulmonary edema, renal failure, severe pressure ulcers. Those are very good reasons to put in a urinary catheter. I just did post-call walk round yesterday, and yes, again, there was a traumatic hematuria, a post-Clexane. The person was given full dose Clexane for PE, and then the catheter was put in. The person did not have urinary retention. So this is from the article as well, and it tells you the steps systematically. Then there's also the feeding assistance. If a person's chronically hungry, hypoglycemic, they can also be a little bit confused. And the sleep enhancement that we mentioned. This is from another article that gives an algorithm on screening for delirium, assessing for the risk, to confirm the diagnosis and exclude other conditions. I like this corner here, exclude conditions other than delirium. possibly causing change in mental status, dementia, depression, acute psychosis, and mania. If no, then you confirm diagnosis delirium. The next page is the part of the algorithm. It was too big to put into one slide. So identify and treat the underlying cause, prevent complications, then manage delirium symptoms. Non-pharmacological is very, very important. So avoid restraints and tethers. Look at that. It says Foley catheters, which is our urinary catheters. Involve the family, orientation and cognitive stimulation. Then pharmacological strategies. These are the antipsychotics. We start low, go slow if it's not a life-threatening situation. Start low, go slow if it's not an emergency or life-threatening situation. And then this is for prevention of post-operative delirium. Education programs is very important, ongoing and provided for healthcare professionals so that your nurses and your team members don't lose morale. If the person is very rude to them, the patient's very rude, and they can come out with all sorts of very insulting comments that they don't take it personally. We'll say that not the person's fault, they have delirium. We know that high-dose opioids, tramadol is very famous for causing nausea, vomiting, constipation, and delirium, and very high-dose morphine. Doesn't mean you don't give at all. It is a good means of pain relief. You just have to monitor for the side effects and tail back if there is. Then the non-pharmacological is very important. The pharmacological, when do we give the drugs to manage delirium? When the person is really extremely distressed, or they are danger to self or others, or it is actually stopping the patient from receiving important medical treatment that will get them better. We know that antipsychotics can cause prolongation of QTC and increased risk of MI and stroke in the long-term usage. The non-pharmacological, distract, reassure, calm, and soothe. Avoid the restraints. They are undignified. They cause injury. But one-to-one nursing is the best. And if we allow carers to room in, like their daughter or their usual maid or helper, whom they know and can coax them. An ultra-low bed for hyperactive patients to reduce risk of injury. You can consider getting these beds for your emergency department, even these trolleys, because suddenly they might get up and climb over a high cot side and get very injured. So we do have these ultra-low beds in our geriatric ward, and we have a few in every ward of the medical surgical wards. What can carer, family nurses do? Sorry, I've told too many stories, so I'm nearly reaching time because my slides didn't take that long. It's just the stories that hold it up. This is Puan Maimuna. Please picture her with me. She's a 79-year-old lady. She's already a little bit frail with a bit of dementia, living at home, has a maid and multiple comorbids. She fell and broke her hip. She went to the emergency. Luckily, it was diagnosed. We had a few who had misdiagnosis as well, but fell and broke her hip, admitted to hospital. Prior to admission, she needs a bit of help, but can still walk with a frame like this. Already at home, she has a bit of the BPSD, a bit of anxiety and suspicious of people. So she is waiting for a hip replacement because there's the logistics of getting operating theater time and money to buy the prosthetic hip. So in hospital, she's agitated, calling for her daughter, refusing food, medication, and IV lines, and tried to hit and scratch the nurse who looked after her. She ends up being restrained, wrists were tied, and boxing gloves, and then an NG tube inserted for feeding and medications, and also given IM haloperidol by doctor on call. So very drowsy the next day. And this is a composite of many patients we see. So it's not just one patient. We see this commonly. So she definitely has delirium with an acute illness. The contributing factors: new environment in hospital, ward is very busy and noisy, strange new faces looking at her, pain, very cold aircon room. The food is not what she's used to. Let's say it's a nice Indian lady who's very used to her tasty, spicy food. Suddenly you get very bland food and given porridge because people think you have a swallow impairment. So paranoid also that people are trying to poison her. We also encourage family members to deliver 1 meal a day to let the nurses help feed the patient or the family member themselves feed. What can we do to make things easier for her? A quiet and calm environment. Delirium is ideally in a single room, but in reality, not many hospitals have these quiet, nice single rooms. Someone familiar to stay with, a daughter or maid. Gently reorientate. But if it distresses the person, we don't persist. We don't keep saying, you're wrong, lah, mom, you're in hospital. Why do you keep saying you're at home? So don't argue, reassure, consider things from their perspective. Good lighting. 1 or 2 familiar items from home, like a blanket or a pillow they're used to, or a photograph, but of course don't bring the whole household. And food from home she's used to, and drinks. Maybe she likes a bit of barley, or she likes a bit of a Milo, our national diabetes-inducing drink. So a few little things to help reassure the older person with delirium. Find out the language she speaks. We are a multicultural team. So if you find this lady only speaks Cantonese or Tamil, let's try and find a team member who can help translate. Always introduce yourself. Don't assume that the person remembers you from this morning or 2 hours ago. Speak clearly, friendly tone, short sentence. Always explain what you're going to do before you do it. If it's like sitting them forward or rolling them over to check them. If she has glasses or hearing aid, let her wear it. Same nurses to look after, avoid moving. And even know if there's any preferences for carers. We have observed a few very conservative ladies. They are afraid of male attendants, for example. So if there's a very attentive nurse or therapist or doctor, they can spot little habits like this. We remove extra lines as soon as possible, because pull-out cause injury. Pull-out IV line also can cause a lot of bleeding, especially if it's not noticed and we have soaked bedclothes before. The bed sheet is full of blood. So ultra-low bed we've spoken about. We avoid cot sites as restraints. We have cases of deaths of strangulation or asphyxiation if they get caught in a cot site like this. So we don't feel that it's secure just to tie them around the waist on the wheelchair or just put up the bed rails. The tying around the waist sitting on a wheelchair, if the patient slides down, there had been case reports of death by strangulation by that tie because it just pulls their neck up. Avoid sedatives and antipsychotics unless very bad. Restraints, we've spoken about it. It causes severe distress to the family and the patient. They will say, my father was tied like a dog. And you hear very distressing reports. Then pain control, temperature, give enough blankets, avoid dehydration like repeated fasting for theatre, then cancel, priority for operating theatre, and as short a stay in hospital as possible, providing at home there's carer training and facilities at home to look after adequate equipment and possibly if they have money to pay for home physio, etc. Delirium may take some time to go away. That's a main thing we have to tell family members. Because they expect that, hey, how come my mother's chest infection is treated? You say antibiotics is finished, but they're still confused. Delirium can remain for weeks or months, depending on how ill the person was, how long he stayed in hospital, whether there's background cognitive impairment or dementia. For some, the delirium goes away completely. For others, they never return to their previous baseline. It is really an unpleasant experience. Some people actually recall being confused, and it may be good to talk about it and acknowledge it, like a debriefing session, and explain the reasons. Some have no recollection at all of the confusion. It's also important to debrief the family members. I had a case where the patient was tied down. The nurses thought she was just being agitated and confused, keep calling. But the poor man actually was not that delirious. He was very, very thirsty because he was given a lot of diuretics for a mixture of chest infection as well as heart failure. Extremely thirsty, had pain from lying on his back all the time. So he kept calling people. The language is different. So in the end, he was just tied up. And when we saw him on consultation, the poor man explained everything. We untied him. He was so sad and upset, he was nearly crying. He says, I'm a person of certain standing. Don't think I'm very poor. I have property, only one house. I put my children through school. So can you imagine how traumatic it was for the person that he was tied down unjustly? And the person, I'm sure, when he goes home, will still have the post-traumatic recollection of being tied down. So these are real cases we see on the ward. People who develop delirium, they are at increased risk of developing dementia in future, not because they had delirium, but because it indicates that they had less brain reserve compared to others who do not develop delirium. So summary, I'm a bit over time, never mind. Delirium is underdiagnosed and under-recognized. Please screen all older people who are unwell for delirium. It is a medical emergency. We need to look for a treatable cause. It's usually multifactorial. AFIDA is the characteristics of dementia: acute, in onset, fluctuating course, inattention, disorganized thoughts, and altered levels of consciousness. ADEPT is the screening tool or the routine that can be done in emergency department, which is assess, diagnose, evaluate, prevent further worsening of delirium, or to prevent delirium in those who are not delirious, and the treatment plan. The screening tools, CAM, which is where I took AFIDA from, but formally it's the confusion assessment method. The 480. Then there's the multi-component non-pharmacological strategy that I illustrated in the case study. Pharmacological treatment, if there is potential harm to self or others, the person's very distressed, preventing the person from getting medical treatment. So we should treat the person calmly and kindly, not his fault. Don't take it personally if they insult a few of the staff members. Delirium may take weeks or months to fully resolve. Some never return to the previous baseline. Some recall it and it's very traumatic and embarrassing. Some develop dementia in future. They have poorer outcomes overall. So we are doing very well if we remember to screen all older persons in emergency department and the ward for delirium. And even in the clinic, of course, if we find that they're delirious in clinic, it is a medical emergency, they need further evaluation. That's my last slide. Thank you very much. I hope people can hear and see me, because when you're speaking like this, you're not sure if people are there. Yeah, I see everybody is still there. Okay, so I'm happy to take questions. I might stop share now. In fact, I'd like to do a new share. Our Malaysian Society of Geriatric Medicine actually has a delirium position statement, and you can write to them and they will send you a PDF copy. So I'm really happy to take any questions and discussion. And thank you for the invitation to come and speak to you today. I hope to be able to speak to you guys about frailty at some stage in the emergency department as well.
So thank you very much, Prof, for your insightful lecture. I do appreciate it. Yes, I have to agree that emergency department is not a good place for patients in the geriatric population comes in with delirium. Maybe some of them develop delirium while they are in the emergency department. And I would like to thank you for reminding us over and over again about the inappropriate usage of Foley's catheter. Yes, some of them are being inserted for the convenience of the staff, just because patient cannot walk. But I think we should really look back into the reason why we want to insert it at the first place. So I would like to open the floor to everyone to ask if you have any questions to be asked to Prof. Tan today. And yeah, please grab this opportunity, because I think she's a very busy person.
It's okay. Of course, I'm so happy you guys invited a geriatrician to speak to you. We have the time, so don't worry about that. Yeah.
Okay, I think there is one question from Leon. For disorientated day-night patient, how is the strategy? Thank you so much.
Okay, for disorientated day-night patient, there used to be some little articles about light therapy, but anyway, we try and orientate them. You know, if the nurse comes to them, good morning, Encik, so and so, good morning, Encik Ali. And now it's morning time. This is breakfast. Would you like me to help you with it? It's gentle reorientation here and there. If it's daytime, we try and give some natural light. For us on 13U is quite easy or better for us. Our ward is on the 13th floor. We have a lot of windows. So we open the window and let them have some natural light. But it's a matter of reorientation. And also we have to be mindful that at night, we don't have too many bright lights on. If it's meant to be nighttime, then everything should be quiet and calm so that people know that it's indicative of rest time. Unfortunately, our wards can be very noisy. You know, our hospital is a tertiary hospital or quaternary, sometimes they call it. So is the other university hospitals. Your admission never stops. You might also have CPR going on suddenly in the middle of the night. But it's just to have the reorientation and have the lighting and the sound level kept down when it's nighttime. Yeah. Do we off the light at afternoon, evening when they sleep, or on the light at night? No, we keep the room darker if it's sleeping time, and quiet is very important. Afternoon, I don't know if they're napping. I suppose we could have dim lights as well and pull the curtains. Yeah.
All right. There's one question from Ahmad. He there, Dr. Tan. Do you have any practical tips to approach patients who were sent to the ED by nursing home in whom there is no reliable carers available to provide accurate history? This is a very good question. I think it's very practical.
Yeah. Practical tips. There's no way of getting a history if there's actually no one. If you've tried your best, you've rung the next of kin, the family members, and you've rung the nursing home, they refuse to pick up or the phone number is wrong. So then our duty is to examine the person very, very thoroughly. And you might then end up sending a bit more investigations. For example, if the nursing home tell you that, oh, this week the urine very busuk and it looks different and passing very concentrated dirty urine, then you focus on that. But if you've no history to help you, you might end up sending a lot of investigations. But ask for one or two people to help you to do the very thorough physical examination. Those missing the perineal abscesses, Fournier's gangrene, those are real cases. I didn't make them up. So a very thorough examination is very important. Yeah.
Okay. Any more question from Prof. Tan? I'm very interested to see the ultra low bed something.
Oh, okay.
Yes, I've never seen it before. Is it available in EDPPUM?
No, it's not yet available, but it's available on the wards. It took us a few years, the tendering process, getting allocation for money, because our own beds belum rosak, right? So what's the reason to buy new beds? But I suppose maybe the beds start to get rosak over the last few years, or our team managed to convince the hospital administration that it's worthwhile that we get these type of beds. I think also sentinel events may have happened in other hospitals, for example, that they realize, oh my, if a confused patient go and fall over the raised cot side, people don't know, the injury is severe, there would have been deaths. So I suppose in everyone's own hospitals, before what we call a sentinel event happens, that means the very bad case scenario, and you think about it and have heard about it, you can present it to the hospital administration. It would be helpful if you had statistics in the past 1 or 2 years that, for example, oh, in my emergency department, we had 4 falls because they were very delirious and they just suddenly climbed out of bed. And this is what happened, you know. And hospital admin people, they'll be worried about lawsuits and negligence, of course. Of course, doctors will know that it's not great, this happens to the patient, but the administration people will look at the legal end of things. The beds are not that expensive. It's just a normal bed, except that you can go very close to the floor. It's nothing so special. It's adjustable height bed, but the lowest it can go is actually very close to the floor. Yeah.
Okay, I see. So will the patient be able to adjust by themselves, or it has to be the giver or the health?
Oh, it's an electric control. So yeah, I think the the healthcare professionals have to adjust it up and down. But I suppose, but if it's a delirious patient, they might not know how to do it. In fact, they might make it go so high up. So I suppose if really delirious, we don't give the control to the patient lah. But I can see it's also useful for a non-delirious patient who are quite short and they want to get in and out of bed easily. Yeah.
Okay. Thank you. So do we have any more questions?
Hi, Prof.
Hello.
I'm Ang here. I suppose this is not a question, but then just a personal feeling regarding the awareness of dementia in the public aspect. It is from my personal experience to my own relatives and some from the patient's parents. You know, like if a patient admitted for certain illness associated with delirium or dementia, if we do pick it up in the hospital and easily explain to the family member, that was fine. But I realized that there's a lot of elderly, they actually do not have a very obvious illness, perhaps just a urinary incontinence, BPH, constipation at home. So they start to behave a little bit different. And very sadly, usually they will be labeled by the family member as being stubborn, being naughty when they got older, and start to have abuse or negligence by family member because of being so naughty. So it is something very difficult to change unless we can really increase the awareness. But just a feeling very sad to look at this kind of phenomenon. I'm not sure what Prof think about that.
Yeah, you've described it, Dr. Ang, very well, that the awareness is not great. In Malaysia, I mean, many people have at least a basic primary school education by now, most. But it's not only a matter of their educational level. It's a matter of health literacy and also common sense. You might even have very highly educated people who are not sensitive to their parents' needs, who just say, my father is stubborn, as you mentioned. So it is really very sad. To raise public awareness, it can be easy if there is a nationwide or a big group. If the government decides to highlight dementia, that'd be great. It'll be in the newspapers. There's a national dementia plan, like in UK, etc. I think the psychiatrists and geriatricians in this country may be driving that, at least as a position statement on delirium by the Malaysian Society of Geriatric Medicine. So awareness is very important. Wherever we have a chance, we should create awareness among our patients. For general public, it'll have to be popular media. Now the older generation may read newspapers, but then other people are on like Instagram or Facebook, that sort of thing. A few of my colleagues and myself, we occasionally go on BFM to give awareness talks. ADFM that Dr. Koo mentioned, they are extremely large and helpful organization. And we will have World Alzheimer's Day celebrations in October, if I'm not mistaken. They will have a big cheerful event like Carnival Light Festival type of event in the Atria shopping mall in that month for 1 whole week in a row. So awareness is poor. To increase awareness, is better to do it at a large scale level than just individually counseling, but we have our duty to individually counsel each person we come across and their family members. And also, we cannot discharge these people without a care plan. I see some pitiful cases where it is like, okay, mother's chest infection is treated, time to go home tomorrow. The family are not prepared for the hypoactive delirium. They come in with terrible pressure ulcers that can kill them. If it doesn't kill them, it has permanently incapacitated them and incapacitated the family. We admit those all the time, that we are seeing the aftermath of a discharge that has not been planned. How do we plan it? We carer train, pinpoint a carer, refer social worker, find out what their financial situation is. Have they money to hire a private carer? If not, we'll have to train the family. The equipment, it could be a temporary hospital bed or a bed rest if they cannot afford a hospital bed. They buy a backing that we can just sit up the patient at home, a wheelchair, bedside commode, etc. Yeah.
All right. you very much. Oh yeah, we have one more question from Ong CY. Hi Prof, can you please advise how to identify delirium in patient with premorbid schizophrenia? Oh, this is challenging, I suppose. Sometimes we might miss delirium episodes and instead treating as relapse psychosis.
Yeah, I agree. You know, as clinicians and doctors, we will never achieve 100% accuracy in our diagnosis. But the wider our knowledge base and our experience level, the less likely we are to miss. So if it's a junior doctor, we're unsure, you consult your specialist or the consultant. But the time frame and the background history is very important. Did the person miss their medications that may have led to a relapse? And is this episode similar to previous patterns of relapse? You know, is the psychosis, the thoughts the same, etc.? Was there any trigger? Is it the psychological trigger or a medical trigger? The very thorough history of comparing before and after and previous relapses. Then we do a very thorough review of checking them over, get 1 or 2 people to help you do the physical examination and the appropriate investigations. A complex older person can have anything. You know, even though they have no ischemic heart disease diagnosed before, doesn't mean this is not their first episode of having a acute coronary syndrome. It's not easy. We also must have an open mind frame that we don't be too proud that, oh, this is definitely the diagnosis and no one else is right. I have unfortunate case recently also, a lady clearly had a stroke. The family members knew she had a stroke. The doctor insisted it was a Bell's palsy and was going to send home. It took a lot of angst for everyone to get her admitted. These are real cases. So if we're not sure, you know, nobody's diagnostic formulation is 100% accurate. Nobody really. As I graduated in 1999, means I've been working for 23 years now. So I think most doctors, we are smart people. We are not the smartest of the smart, but it's from being conscientious and having experience. We see cases, we share our experience. That's why we like to tell stories, right? Then the more you see the pattern, the more you learn, and the less likely we are to miss a diagnosis. So I don't know, Dr. Ong, have you had a patient like this, whether you'd like to also try it, to share some experience that you actually had a schizophrenic patient who might be delirious.
Hi, Prof. Tan. Good morning.
Hi, good morning. Hi.
Actually, I'm a MO working in Institute Psychiatry, managing psychiatry patient. Recently, I had a patient in the ward. This patient was actually diagnosed with schizophrenia late 50s. It was diagnosed from other hospital from one of the psychiatrists. And what we have managed to trace, the patient had been sent for CT brain and the other dementia workup, and all turns out no significant finding lah. All the investigation was done last year, I think 2021, somewhere around March. So this time around, actually family members brought the patient because patient had so-called abnormal behavior for nearly 2 months at home. And they brought to several psychiatrists giving a different treatment, antipsychotic, but eventually patient still looks confused, and orientation-wise is like fluctuating. And then admitted to our ward, we tried to do a thorough physical examination. Patient doesn't have any neurological deficit, ambulation-wise okay, but patient is very confused, orientation-wise is totally out lah. But ADR-wise need to be supervised by the staff in the ward. We started medication for him, but unfortunately he doesn't respond after 5 days. So we sent all the bloods are all normal, ECG normal, X-ray came back also doesn't suggestive of pneumonia lah. So in the end, we sent for CT brain after nearly 5 days in the ward and turned out to be multifocal infarct. So this patient will have probably missed the period where he might probably have some acute infarct upon admission.
Yeah, actually, when you see multifocal infarcts, it's very hard to know which of them are significant unless the one site of the infarct is quite big, like for example, in the frontal lobes, or they have very severe microvascular disease that when you see an MRI or the CT scan, they will say Fazika score very high, like 3 and above or whatever. So I think in these cases, if you're concerned, I don't know if your hospital has access to a physician or neurologist who may be able to consult in. There are the rarer cases of the encephalopathies, as Dr. Koo mentioned earlier, but those are the rare diagnoses. And if we don't see many, we have lesser chance of diagnosing it. So it's from the years of experience and also from attending CMEs and listening to patients. I saw the doctor who got the answer Hashimoto's encephalitis earlier, who got it correct in the chat box. I personally know that doctor, excellent doctor, and I asked him, oh, great, you got it. He says it's because he saw a case before. So we share experiences. That's why we have grand ward rounds where we present cases to other teams. So I'm not sure whether even the multifocal infarcts is the cause in your patient. So if you're really struggling, it's best to get a physician's or neurologist's help to see if there's anything else missed, the very rare things. In UK, we had the prions disease. Do you remember mad cow disease from 20 years ago? Then they killed a lot of cows and people were buying beef for a very low price to eat. So there are many weird and wonderful things out there. Yeah.
All right. Thank you very much for the questions. Very good discussion coming from the participants as well. So if we do not have any more questions, we already a good time to end our session today. Again,
yes, we're over time. I'm so sorry. I'm very long-winded.
Please do not say sorry. I think we are more grateful to have this kind of what you call that interaction, so that we can share our experiences, difficulties, and maybe there's something that we can do about it. Maybe something that we cannot do anything about it, but it is worth to have to understand each other's limitations and also strength. So I'm just going to end the recording for now. Just hold on for a while.